Except Wednesday, I'm free on other days.
Okay,
Wednesday, this time I'll be traveling back.
I didn't know that. I will take care of that.
Over to you, sir.
Yeah.
Yeah, Prasha.
Yeah. Good afternoon, doctors. Yeah.
Yeah. Please, you start.
Yes. Good afternoon, doctors. Welcome to this webinar on role of Oseltamivir in influenza management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, as you know, the journey has begun in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Hetero Healthcare is the largest closely held pharmaceutical company in India and is amongst the largest manufacturers of ARV, APIs and FDFs in the world, and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India, with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare was awarded the award for Pharma Excellence for COVID drugs. Today's webinar, the moderator is Dr. N. L. Sridhar sir, and with Dr. Sri Krishna and Dr. Pawan Kumar as speaker. Welcome Dr. Sridhar, welcome Dr. Sri Krishna, and welcome Dr. Pawan Kumar. Dr. Sridhar sir is practicing since 20 years. He is professor at Apollo Hospital of Medical Science and Research, director at NeoBBC Hospital, Hyderabad, treasurer secretary at Twin Cities Branch 2122, 2324. Sir is joint national coordinator CIAP 24-25 Presidential Action Plans, secretary PITS 25-26, medical legal expert, and has major achievements of 7 national and 1 international publication. Additional chief organizing secretary Pedicon 2025. Organizing Secretary APPA Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, Vaidya Ratna Award 23 from BC Roy Motherfount. Welcome, Dr. Sridhar. Dr. Sri Krishna Suram today, sir, is MD DNB, consultant pediatrician, and professor of the head of the Department of Pediatrics, Apollo Institute of Medical Science, Hyderabad. Welcome, Dr. Sri Krishna, sir.
Good morning.
Dr. Pawan Kumar is Professor of Pediatrics, MNR Medical College, Consultant Pediatrician, Omega Clinics, Scientific Convener, National Pedicon 2025, National Advisory, Indian Pediatric Journal, with Fellowship in Allergy and Clinical Immunology, Postgraduate Diploma in Medical Nutrition, and Postgraduate Diploma in Developmental Neurology. Sir has won several awards, just to name a few: Bharat Gaurav Puraskar Award 23, Best Pediatrician of the Year Award 2023, Vaidya Ratna Award 15, OGU Outstanding Academician of the Year 2023, Dr. APJ Abdul Kalam Health and Medical Excellence Awardee 2021, COVID Warrior Award, Asia's International Research Award 2023, Eminent Doctors of South India Award, Best Researcher Award 2016, 18, 22, 23 by MNR Educational Trust, Dr. Y. R. Reddy State Gold Medal, and Dr. Chandrasekhar Chaudhary Gold Medal Awardee recipient. National Award winner of Dr. V. Balagopal Raju Gold Medal for Scientific Research Paper 2010. With this brief introduction, I hand over the session to Dr. Sridhar. Over to you, Sridhar, sir.
Thank you for a nice introduction about myself and all the panelists. So kind of you. First of all, I want to thank Hetero Pharma for coming forward to this educating webinar where the need of our and also uh, apt to coming post monsoon season. So it's an apt webinar always. So let me share the screen. So able to see, sir?
Yes, clearly.
Yeah, that's great. So today's topic is role of oseltamivir in flu management. We have our panelist, Dr. Srikrishna Garu, Head of the Department, Professor of Pediatrics, Apollo Institute of Medical Sciences and Research, Jubilee Hills, and also Dr. Pawan is the Consultant and Professor of Pediatrics from Sangareddy, MNR Medical College. So, welcome you both for this board for panel discussion of role of Oseltamivir in flu management, sir. A brief introduction on the contents, what contents we are going to concentrate. One is healthcare challenges in monsoon and their diagnosis, and influenza complications, clinical evidence of oseltamivir, and guidelines recommendations of empiric use of oseltamivir. Coming to the India and flu disease, what we know about influenza in India. So, and which season it predominant in which season, and also correct time to vaccinate. These are the basic questions where we have to tell the practicing pediatricians and also postgraduates to concentrate more on this season and also vaccination time. So, coming to the influenza, influenza is a very much naughty virus which frequently changes its genetic variation, so that's why we go for vaccine the strain subtypes or strains every 1 year. We have to, because we don't know the genetic variation when it will change. The shift and drift which occurs in the influenza is very rapid. So second is we have to, it's influenza virus, it can cause fever, headache, body pains, and also myalgia and weakness, everything. And it simulates most of the viral like infections, and also severe respiratory tract infections, and also some of the viral adenovirus. This also will have the differential diagnosis for influenza A. And now recently the golden drug, which is oseltamivir, came into the pharma treatment, where medical treatment was changed rapidly, and on OPD basis, also outpatient department basis also, that we are able to cure the influenza A or B infections. So this is the brief. And about season, yeah, you can see 5 to 10% of the influenza cases are acute respiratory emergencies, and also 10 by 10 for 100 children a year suffers from influenza. And influenza associated acute respiratory infections are 33 to 44%. And you know very well, in 2009 there is a pandemic which had shown 22.8% positive for influenza, and up to, it's a huge number, sir, 30,000 plus cases are positive for influenza up to 2019, and out of which 1809 is mortality is there. And this is the where which season. So these are there are two spikes where from January to April there is a bigger peak, and July to September there is another peak. In these 6 months, child will be, most of the children will be affected with the influenza A or B. Influenza A will be around 60 to 70%, and influenza B will be 20 to 30%. So out of which you can see, and so the best time to vaccinate the child is May, June, and also November, December, in order to avoid the peaks. And it depends upon the part of India where the predominance spikes are there. In our Telangana, we have seen the spike in July to September. And you know, there are few studies in the next slides, I can tell, in post monsoon effects also, post monsoon time also, the cases will be more. So this is one more global burden of disease 2017, where I will not go in detail. I will read only two things. More hospitalizations number 5.88 lakhs, and deaths are 26,000 deaths are there because of the lower respiratory tract infections with complications. Both the mortality, morbidity, and hospitalizations are given in the slide. And I will mention only 2022, 12,881 cases registered, out of which 399 is death. So if you, at the right time, right management, right treatment, if you give, definitely these deaths can be controlled and the mortality can be brought down. So this is another bar diagram where in the cases of influenza infections, in if you see the blue color, 2019, 28,798 cases are registered, and the second graph shows bar diagram shows 12, 18 deaths in 2019. So the incidence of influenza and related deaths increasingly alarmingly in India. So we have to, on war food basis, we have to treat the kids. So patterns, as I will not stress more, in southern India like Telangana, Kerala, Tamil Nadu, and Karnataka, September to November is the peak season. And there is a beautiful study in Tamil Nadu, 7 years cumulative study in King's Institute of Preventive Medicine and Research, where 36,670 specimens were subjected to influenza analysis, where influenza positivity started with the onset of monsoon, peaks during the post-monsoon months also. That's why we should be careful not only monsoon time, in post-monsoon also, we should be think of if any child comes with cold, cough, fever, toxicity, with myalgia, with headache, we have to keep in our mind influenza also. And there is the differential diagnosis, influenza-like illness and H1N1 and severe acute respiratory illness and COVID-19. So we should be able to differentiate between influenza-like illness and severe acute respiratory illness and COVID-19. So let me request Sri Krishna Surampudi sir to tell about types of influenza virus and their how it spreads. Please, sir.
A very good afternoon to all. I thank Hetero for giving this opportunity. As traditionally we know that the vaccine also available nowadays, even for the strains. So there are the three types of strains are identified for the influenza virus: influenza A, B, and C. And in this, A is most virulent, and it is a cause for the frequent epidemics, and also due to minor antigenic variations and periodic pandemics. Whereas a B virus mainly infects children, and that too less than 5 years, and sometimes it causes local epidemics. Whereas influenza C virus is the one which recently we had a swine flu, the word swine flu, that was the main reason for it. And it is generally cause a mild respiratory illness, and not thought to cause epidemics in general, but it happened previously. Now, presently in the subtype A also, recently we got many cases of H1N1 and H3N2 influenza viruses. Now, regarding the transmission, as like any other respiratory virus, it transmits mainly by air droplets. When the people suffering with the flu, they cough, sneeze, and talk about that. And sometimes even the hand to transmission also known for it. That's why we insist for the regular washing of hands properly whenever there is some epidemic is there. And the most healthy adults may be able to infect other people right from the day one of their infection before the symptoms develop till 5 to 7 days after they become sick. Whereas for the children, some children, because of the immunodepression, they tend to pass the virus for more prolonged period, 7 to 14 days. These are a differentiation between the ILI, H1N1, SARI, and COVID-19. Not much of difference. All are like a typical respiratory viral infection presentation with lung involvement, where the breathlessness, cough, and fever is the most common for all of them. Can we differentiate them? Means the risk of breathlessness is more in H1N1 and COVID. And one peculiar feature of COVID, as everyone knows, that there is a loss of smell and loss of taste. And also the other system involvement like diarrhea is noted in COVID-19. Whereas otherwise, most of the times it is really a tough job to say that which particular virus is the cause for this fever and breathlessness. And here the treatment part, the recent aspects from last 15 years, this Oseltamivir is available to treat these viruses. Even though there is no particular antiviral drug available for all other viruses, among the all, the influenza is the one which is known to cause epidemics and it is there from last 100, 120 years also. Epidemics were there. Soon after First World War, there was a huge epidemic in India. Almost we lost 5 to 6 lakh people due to flu epidemic followed by a pneumococcal infection. And here, now presently the drug is available for this dreadful disease of Oseltamivir, and there are some studies shows that it is a very effective in using when you use the cases with influenza like illness, and it shows that it reduces the severity. Second, it reduces the complications, and also the period of suffering also shortened. That means the duration of the flu suffering also will be reduced because of the Oseltamivir early usage. Next.
So thank you, sir. The message is here. The influenza, if you start the oseltamivir treatment for the influenza, it reduces the antibiotic use by 26.7% and influenza-related lower respiratory tract complications by resulting in antibiotic therapy by 55%. And most happiest thing is it reduces the hospitalization by 59%, sir. So, whenever a case comes to our clinic or a hospital in emergency, if you feel that child is having headache, body pains, and breathlessness, and also if you feel that child is having viral infection, uh, before after sending the viral panel, before getting also, we can start the oseltamivir, by which hospitalization can be reduced and antibiotic use can be reduced. Can I request Dr. Pawan to tell about this first case scenario, which is very interesting, please? Pawan. Pawan.
Sir, very good afternoon, sir. Thank
Yeah,
you.
please.
Thank you so much for giving the opportunity, Dr. Sridhar, sir, Dr. Sri Krishna, sir, and Dr. Prashant. So this is a very important, pertinent subject because nowadays we are seeing a lot of cough cases, and I think cough is the one thing which we need to really address. And if it is because of flu, then nothing like that. That will be the worst cough. The parents will describe that as this is the worst cough the child has encountered anytime. So this is not only disturbs the child, but also the family, also the neighbors also will get affected with this. So this is the second most common reason why a parent visit to a pediatrician most of the times. The first one being the fever always. So let us discuss this some interesting cases here. Here is a 4-year-old boy admitted with a history of fever for the last 6 days along with the cough and cold since 5 days. On examination, this child is having a respiratory rate of 45 per minute, and that too with irritability. So 4-year-old child with a respiratory rate of 45 definitely being tachypnic. And the chest auscultation, you can see, we can hear there is a bilateral crepitations can be heard. And other parameters were normal. The child weight is 15, as expected is 4 years is 16 kgs. His weight is also very good. How do we proceed? What is the initial management? These are the basic doubts which we get. So what are the basic investigations should be done in this child? Do you start an antibiotic on the day of admission itself? If so, which antibiotic? This is a common question. How do we proceed? Whenever the child is sick and is a tachypnic with irritability, please act immediately. We need to start oxygen in a non-threatening manner. Here's the catchy word is a non-threatening manner. You should provide the oxygen in a non-threatening manner. If the oxygen levels are also low, always provide with a non-rebreathing mask. Simple face mask may not be helpful there. So start oxygen in a convenient method as the respiratory distress is there, and supporting things. Once you take care of the airway and breathing, then we need to address the cardiovascular circulatory thing, that is in the form of IV fluids. What basic investigations usually, because whenever the case of respiratory distress has come, we need to do some basic investigations which will give you a lot of clue. So here can go with CPP, complete blood picture, and chest X-ray. So do you start an antibiotic? Because here we don't know the etiology and we don't know exactly. Here that is the importance is we need to differentiate whether it's a viral or bacterial. But most of the settings in resource poor settings, especially when there is no idea of differentiating, then as per the IMNC guidelines, we can start amoxicillin as the basic drug. And once you can start early and you can hit early, and you can when it is proven that it is viral, then you can withdraw also. There is no harm in withdrawing that. But yeah, here you can see that complete blood picture for this child has came to be normal. But chest X-ray, this is the typical picture. I am sure all the pediatricians who are here, they might be seeing this type of X-ray with a bilateral interstitial infiltrates, which is classical of this flu. So this type of, they look like pneumonic, but bilateral interstitial infiltrates are very commonly seen. And this child, because we are affordable here, the parents are affordable, we have sent a viral panel. The short viral panel doesn't cost more than 3,000. You will get the report in a day. And for this child, we got it in, influenza A, which Dr. Srikrishna are telling as a very dangerous virus because it causes all the complications happens because of this virus, influenza A. So for this child, H3N2 was positive. So antiviral drugs definitely have a big role. High index of suspicion is what is needed here, because the more you delay, the more effect will not be that great. So that's why the guideline says antiviral drugs, they can shorten the illness if started within 48 hours of symptoms and should be prescribed by a doctor, as antibiotics are ineffective against the virus. We all know that. Not only that, they are ineffective, but they can cause antibiotic resistance, which every pediatrician never wants to happen, right? So it's like giving an antibiotic for a viral infection is like opening a neighbor's door with your key, which will never happen, right? So Oseltamivir, this dosage is, I request all of you to remember this dosage. It should be started 3 milligrams per kg per dose. Very simple to remember. It is available, fortunately, for pediatricians. We get it in a syrup formulation, and which should be given BD for 5 days. And that is the dosage which everybody should remember. And the emergency warning sign, this we have to tell every parent. Write down on the prescription, if the child gets these symptoms, rush to hospital immediately. So what are those? Especially the fast breathing, the troubled breathing, bluish skin color, not drinking enough fluids. This is one important aspect. The child who is breathing with difficulty and all, he will not take fluids also. The water intake also goes down. That is a warning sign for us. And not waking up or not interacting. Child is drowsy, sleepy, and breathing very fast. That's a important. And the child is irritable. Being so irritable. Irritability is one sign that, his CNS is getting involved. So these children should be rushed to the hospital as early as possible. Next slide, sir. So the complications of flu, this is very important. We need to educate the parents because they should not take it very lightly, because once it has come, the symptoms have already started, it can suddenly worsen to ARDS also. So it can cause viral pneumonias are very common, bronchitis, ear infections, middle ear infections, and worsening of existing diseases like asthma and COPD. That's why especially children with asthma should get this flu vaccine. And along with that, with high index of suspicion, whenever we see that wheezing, breathing difficulty, and child is very sick looking in an asthmatic child, we need to definitely start Oseltamivir as early as possible. So treatment is largely supportive. The bed rest, the child should be given a bed rest, increased fluid consumption because the child will not be able to take. Cough suppressants definitely is, there is no big role there. We need to increase the fluid, and some home remedies will definitely do. If the child is having fever, always use paracetamol as the first drug of choice. And if there is a child is very having the fever and body pains and all, then you can use NSAIDs also for that. Luckily, most patients with influenza, they recover within 3 days. This is what we usually see in our day-to-day practice. But other viruses like RSV and adenovirus, in this season we have suffered a lot. Almost the patients used to stay for more than 5 days in the hospital, and it existed for 15 days. Thanks to influenza and thanks to Oseltamivir, that can reduce the hospital day illness. Next slide. So this is very important. There are two types of antiviral drugs which we have. Fortunate one is that neuraminidase inhibitors. Why I say it as a fortunate is this is active against both influenza A and B. The examples of Oseltamivir and Zanamivir, because this is very important to understand. This blocks the viral neuraminidase enzyme, which is critical for the releasing of virions from the infected host cells. once the host cells are infected, these cells multiply inside the cell and about to blast like a bomb. So this neuraminidase inhibitor, it will block that enzyme which is essential for the release. So that's why it will not only helps in the treatment of the child, but also it will also help in preventing the spread from this child to the other children. So that is why neuraminidase inhibitors are more preferred. Other drug group is adamantins. These are like M2 ion channel blockers. They also interfere with hydrogen ion channel activity of the influenza A virus, thus blocking its entry into the host cells. This will stop the entry itself, whereas neuraminidase will prevent the release of from the cells to the body. So oseltamivir, fortunately, this is a potent and selective inhibitor of neuraminidase enzyme of the influenza virus A and B. It's a prodrug which is converted into active form, which is oseltamivir carboxylate in the liver. It inhibits the influenza viral replication and pathogenicity, which we have seen, and it prevents further spread of infection. This is most important because it will stop the release of virus into the body. It is effective against all strains of influenza A and B, including avian H1N1, swine origin of H1N1 and H9N2. All the flu categories will be protected by this. So this is the slide where I told you how the virus, once it enters, it captures the cell and how it multiplies. The genetic material will multiply there, and you can see the budding virus coming out, and neuraminidase cleaves the receptor. So that is not there. If neuraminidase inhibitor blocks that, and it will prevent the virion release, so thereby it halts the viral replication also. So that is the power of neuraminidase inhibitor. Next slide.
So,
So
thank you, Pawan.
yes, sir.
So it was the first oral neuraminidase inhibitor, and Oseltamivir, beauty of Oseltamivir is it works on both influenza A and B, but other antiviral drugs will be acting on only influenza A. So we should take care, because we see in our practice influenza B also most of the cases. So we can start initially Oseltamivir, and it is approved in more than 100 countries. FDA, CDC, and American Academy of Pediatrics approved. So the second case, a beautiful case. I request Sri Krishna Garu to start the second case, sir.
Okay. Here, a 6-year-old girl came with a fever and rhinorrhea for 6 days, with a cough for 3 days. This is a known case of bronchial asthma on irregular treatment. The extra additional problem for this particular child is a known case of bronchial asthma. As you know that the incidence of bronchial asthma cases is increasing. Almost in India, they say that 20%, 18 to 20% children are having allergic rhinitis and bronchial asthma. Here on examination, there are severe bouts of cough, but less fever, with bilateral crepitations with mild wheeze present. That means it is looking like a mixed picture where both the infection causing the pneumonia or viral pneumonia along with bronchial asthma features. So, do we suspect flu infection in this child? Because the previous history of rhinorrhea and fever, we have to suspect definitely that there can be some viral infection. Then what is the criteria? Then whenever there is an upper airway infection and cough, so two areas are involved in a short period, always suspect the viral infection. Our worry is that this child is a known case of bronchial asthma on irregular treatment. So there is every possibility of worsening of the situation. Next. So how do we suspect flu infection in the child, and what is the criteria? First thing, one thing we have to remember, that any virus can trigger asthmatic attack in children. On other hand, influenza is one of the most important virus which can trigger asthmatic attacks in a known case of asthma. Moreover, even similarly, the patient with asthma who is having that chronic respiratory changes in the lungs are known to get more frequent viral infections and also secondary bacterial pneumonias. So this flu infection can potentially prolong the illness with persistent severe cough. And here the dilemma also comes that because the fever is there and do we go for a steroid? Because the bronchial asthma, the standard treatment is always steroids. But can we give steroids? In this case, if you give steroids, the infection will aggravate. And if you give only antiviral drug or antibiotic, then we cannot make the symptoms of bronchial asthma persist like that, because the child is having breathlessness. So that is a dilemma with this sort of cases. Next. So as I told, that can we prevent? Because every asthmatic child need to receive influenza virus throughout their life, as long as these symptoms are persisting. So here in such cases, whenever there is a case with the dilemma of the viral infection with in a case of asthma, empiric treatment by antivirals is strongly recommended, and it should be started as early as possible. You need not wait for the viral panel to come by lab confirmation. And on the other hand, negative lab test of H1N1 does not exclude the diagnosis of all patients. So early initiation of the antiviral drugs is strongly recommended for such type of cases. So preventive treatment with Oseltamivir can save the child also. So they give what is early empiric supportive therapy and monitoring, like give empiric antimicrobials to treat all likely pathogens that are causing acute respiratory infection, and empiric antibiotic therapy should be given as per the guidelines, standard guidelines of IMNCA. And empirical therapy with antiviral is the one which we would like to, because the symptoms are mimicking more of viral infection. So instead of depending on the antibiotic, it is better to start antiviral also. So obviously, it is a oseltamivir is a drug of choice. Next. So in adults with community-acquired pneumonia who test positive for influenza, the treatment regimen includes the anti-influenza treatment, and it should be prescribed for all patients with positive influenza. On the other hand, there are reports saying that there is a reduced risk of death in patients hospitalized with community-acquired pneumonia who test positive for influenza virus. Similarly, the treatment should be started as early as possible. Like we can recollect previously, every case of infection, we used to start antibiotics. Then later we have seen in encephalitis also, whenever a sporadic encephalitis do come, acyclovir should be started irrespective of the result. Similarly, in flu cases also, the viral respiratory illness cases, you can start oseltamivir straight away. Next. So this particular case is having a CPP showing normal picture, but the X-ray shows the bilateral interstitial infiltrates with hyperinflated lungs. And this particular case also having viral panel positive for the H3N2 of influenza A. So that is confirmatory. So only thing is, these viral panel takes at least 1 to 2 days time in many places, and in many places it is not available. Do we need to wait for it? Means no. Whenever there is a risk for a child with chronic respiratory condition like bronchial asthma is there, straight away you can start oseltamivir. So this case was managed with oseltamivir along with asthma treatment. Apart from supportive therapy, initially we didn't give steroids, only frequent bronchodilators we gave it. Afterwards, once the fever controlled, she is discharged with prolonged asthma therapy.
Yes, sir. Thank you, sir. Why this case was kept? Because there will be a confusion. Child is already known case of bronchial asthma. Child is presented with distress and breathlessness and cough and cold and fever. So it is exactly mimicking the influenza. So we have to differentiate. If the child is asthmatic also, the influenza can aggravate the asthma also. The any inflammatory, not only asthma, any comorbid conditions will be definitely aggravated by the influenza infection. So we have to keep in mind, and we have to treat parallelly both the uh, uh, clinical scenarios of asthma and also influenza. So we in this case we started with oseltamivir, child improved and discharged with prolonged asthma therapy. And this is another interesting case. I request Pawan to.
Yeah. Thank you, sir. After that wonderful talk by Dr. C. Krishna sir about that case, that was a very common case which we encounter nowadays. Here, another case, another important case where a 2-year-old boy admitted with high grade of fever for 2 days, along with cough and cold for 2 days and breathlessness. The important point is breathlessness here. 2-year-old child who is restless with a respiratory rate of 60 per minute and fever of 103 should be definitely be alerted. So now let's see what is the initial management and do we need to start any presumptive anti-flu therapy with oseltamivir and what is the criteria? There are clear-cut guidelines which are laid here, which we are going to discuss. Next slide. So what is the initial management? Because any child who is having very sick with high grade fever, with respiratory distress, start always with supportive measures immediately with oxygen support, which we discussed. Give always because the child is always irritable, crying and all. Give it in a non-threatening manner and IV fluid should be taken care because the child fluid intake also will be very less. So if needed, in any case, the child needs ventilatory support also. Sometimes we need it. And the role of preventive antibiotics, yes, because here till we get conclusion, better as per the guidelines, IMNCI guidelines or the hospital policy, do start with a basic antibiotic. Do you want to start a presumptive anti-flu therapy with oseltamivir? This is a common doubt every pediatrician gets. So, but here there are the guidelines, how when to start this presumptive antiviral therapy. So it should be started when you suspect, especially the season, when the season is on like that, like past 3 months we are seeing there was a huge season. Every child who is having a worst cough with high grade fever, sick looking, always have a high index of suspicion. Suspected like influenza like illness, fever with either cough or sore throat. Confirmed influenza, especially in the hospitalized, it's always better to get the test done. And the child is worsening or so condition is progressing. Always think of giving a presumptive antiviral therapy. If the child is having underlying conditions, especially asthma and any immunosuppression conditions, always try to do it preemptively and start immediately anti-inflammatory antiviral therapy. Antiviral treatment should also be initiated as soon as possible, regardless of the duration of the illness. Don't think once they works best within 48 hours if you initiated, but even though if they come late, don't hesitate to start when you suspect, when you have strong suspicion. Here in our case, when we do complete blood picture, this child showed lymphocytosis and with a neutropenia. And the same picture, what we have seen in the first X-ray, the same bilateral interstitial infiltrates what you need to identify on the X-ray. And this child was also sent for viral panel. So this is the most common. Even Kukatpalli, we are seeing this is a common virus which is being identified. Now let's see the dosage. I request all the pediatricians to note down this dosage schedule and keep it as a card. Make it as a card. And I request Fluvir team to get this card and distribute to the pediatricians, because if it is there with us, it is very easy to deliver the dosage without any much time. But if you remember the dosage, 3 mg per kg twice daily, that should be given as a treatment. But when it comes to prophylaxis, see that all the dosages should be given once daily here. So that is the difference between prophylaxis, chemoprophylaxis, and that should be given for 10 days, whereas for treatment we give her only 5 days. So this is very important to understand. And fortunately, if you can see the drug dosages in the children according to weight, they were, stratified. And you can see less than 15 kg, 60 mg per day should be given twice daily and 30 mg once daily for chemoprophylaxis. That comes to 2.5 ml. You can remember less than 15 kg, 2.5 ml twice BD like that. So this card is definitely must have onto your, prescription table. Next slide, sir. So again, there is some short glitch here. The same child is having another 5-year-old sibling with a nephrotic syndrome on steroid therapy. Now the child is undergoing that immunosuppression, and this child is exposed to our current child. What is the risk for him, and do we recommend any preventive therapy in this child? So let's see. There is no role of any vaccine now because the child is already exposed. No role of vaccine for the child who is on steroids. We know that guidelines, there are certain conditions where you have to defer vaccination. You can't give vaccination when the child is on steroids in the immunosuppression therapy. He should receive prophylactic antiviral drug. That's where the boon. Oseltamivir comes as a boon. You can immediately start antiviral drug, and this will definitely reduce the duration of the illness, severity of the illness also. And the dose is same for this boy also, but here it is OD because we are giving it as a prophylactic. The idea of this case is to ensure that the other children who are in the family, they should get at least once a dose, OD dose of this 3 mg per kg per day. But here it should be given for 10 days. So can we give the details of prophylactic? Yes, sir. Yeah. So antiviral treatment in OP setting is what is very important for symptomatic children who are not at high risk of influenza complications with suspected or confirmed influenza disease. If treatment is can be initiated within 48 hours of illness, this is where which we should not miss this golden window of opportunity. Antiviral treatment may also be considered for children with suspected or confirmed influenza disease whose siblings are household contacts, like in our case, and either are younger than the 6 months, either are younger than 6 months of age. Because less than 6 months, if the child is suffering with flu-like symptoms, do not hesitate because the complications will be higher in them, and they have a high risk condition that predispose them to complications of influenza. So this is where we need to play upon. So preventive antiviral therapy, yes, antiviral chemoprophylaxis is recommended for the prevention of influenza virus as an adjunct to vaccination in certain individuals. Definitely, vaccination will definitely curtail the disease severity. And those who are exposed to symptomatic children, especially the contacts in the home, other siblings, and who are at high risk of influenza complications but are not yet immunized, these children should be given preventive antiviral therapy. And last but not the least, those who are not expected to mount an effective immune response with vaccinations, especially, do not hesitate to initiate antiviral therapy.
So, the good message, Pawan. See, we kept this case because we have to thank Sri Krishna garu. This case belongs to Apollo Institute of Medical Sciences, and we have taken permission from head of the department, Sri Krishna garu, and we are giving these cases. Why we kept this case? Because the case scenario is totally different. There is a treatment part and also prophylaxis part. So, in the treatment part, easy to remember in syrup form. 5 ml contains 60 mg, 1 ml contains 12 mg, and easy to dose more than 3 mg, easy to remember 0.25 ml per kg per dose. And twice a day for treatment part, and chemoprophylaxis can be given OD dose for 10 days. So the suffering child is having the other sibling who is having a comorbid conditions, nephrotic syndrome, and on steroids. So this is the message where we have to like mop up program, whatever the word you want. If the child other children are having the similar complaints in the house, and the diagnosis is one child, suffering child, or the child gone to the doctor has diagnosed as influenza, and viral panel was confirmed that presentation, definitely the other children, if they are having cold and cough, better to give the oseltamivir chemoprophylaxis like 10 days OD dose. That is the message for the from Dr. Pawan. Thank you. Now the one more interesting case by Sri Krishna garu, please, sir.
Okay. Here is one more interesting case. A 12-year-old girl admitted with fever and joint pains for 4 days, along with mild cough for 2 days. She is not a known case of a chronic lung disease. And clinically, the child is restless, along with cough and low fever, but a mild arthritis is present and bilateral crepitation is present. So this picture is more looking like some connective tissue disease. But only thing is because the respiratory infection is there, bilateral V's and crepts are there. Can we relate any viral? As some of the viral infections are known to produce the picture of connective tissue diseases, that multi-system involvement in a short period, and especially joints and skin involvement. So this case, particularly CBP, shows the normal picture. X-ray shows the bilateral interstitial infiltrates as a hyperinflated lungs you can see in this X-ray picture. ANA profile was normal, but the viral profile shows the influenza type B positive for it. Next. So what is the association we get with these connective tissue diseases? Is there any evidence? Really, actually, after seeing this case, I've gone through some any associations there. So among the various connective tissue diseases, only ILD, that is interstitial lung disease, is known to have association with influenza virus. And virus also, the influenza virus also can trigger or the ILD in a long course if not treated properly, a chronicity. If it ends with chronicity, this influenza virus can cause in a interstitial lung disease in a long duration. Similarly, if already known case of ILD, if they are get the flu infection, then the chance of complications is also very high. So, frequent viral infection might play a role in the development of progression of connective tissue diseases. Then that is this is one reason in Western society, as we know, in the US and European society, the incidence of connective tissue disease is very high. So this is one reason why they advise all age groups throughout life yearly one dose of influenza vaccine also. That means because influenza is known to cause multiple problems. It can get worsen in the immunocompromised patient. It can cause worsening of the connective tissue disease also. This is one reason why they advise regular vaccination. So when signs of viral pneumonia, obviously you need to start Oseltamivir in early in such cases. Next. So then we get doubt in this particular case, influenza B is came positive. We get doubt what is the role of influenza B, how severe it is. Is there any change in the clinical picture medication? We have gone through the literature which says that it is influenza B as such is a mild, it should be. It is more severe in children less than 5 years age. And even the clinical picture is same both A and B. And the medical management also same because Oseltamivir will work against both. And at present the quadrivalent vaccine is available, which is also useful for A and B. On the other hand, influenza A is known to have more severe illness, more epidemics, and even more complications of pneumonia or post-viral infection. Next. So what are the preventive measures we do have in such cases? We have many pharmacological and non-pharmacological measures. As non-pharmacological, hygiene of the hand hygiene and water hygiene and air hygiene are the main thing, and we need to follow the cough and sneeze etiquettes and maintain the cleanliness in the every area. Whereas pharmacologically, it is better to go for vaccination annually, and also whenever you suspect a case or somebody in the family is suffering with the problem of influenza, better start prophylactic Oseltamivir. Next.
So the fourth case was very interesting, sir. There's a connective tissue disorders. So because the child is having arthritis, normally in influenza-like illness and influenza, the arthritis will not be a complaint. So here the case is somewhat a confusion is there. Age is 12 years and also the child is having arthritis. So that's the reason why we have to think of connective tissue disorders. And you know very well, influenza always flares up all the comorbid conditions. Maybe asthma, maybe nephrotic, or maybe other symptoms involvement. So they will flare up in the influenza. So that's the reason why we kept. And one more important is the diagnosis is viral panel was sent, influenza B was there diagnosed. The previous three cases are influenza A, but this case influenza B, where only Oseltamivir will act aptly for influenza B. That's the reason why SAR had kept this case. So very interesting case, sir. Thank you for that case presentation, sir. And one more question for Sri Krishna Garu. Has the incidence of viral infections increased, sir? What could be the possible reasons?
Actually speaking, because for two reasons we can say that the viral infections are increasing. One is whenever there is any fluctuations in the any area with weather fluctuations, the chance of getting viral infections, because the virus will get modify itself and the chance of getting viral infections are very high in such cases. So we have seen that after a tsunami, there is a huge rise of flu cases. And similarly, if you go back to the last 100 to 200 years, after every natural calamity, there is a rise of flu cases. Where in general, viral infections, among that, flu is known to give, because we know that there's a antigenic shift and drifts are very well known for it. So definitely we can say that the number of viral infections has increased.
Okay, sir. Thank you, sir. So the next question, Pawan. Generally, how soon the child is brought to a pediatrician? In your experience of 15 years, Pawan?
Yes, sir. Yeah, that's a very pertinent in the practical question, sir. So every parent, I think it's our responsibility, our pediatricians only to educate every visit when to how to identify the red flags and all. Because the more the child was delayed at home, so this is a common practice in the parents that common fever only, let me try these medicines, and they try first, and they will go to a local doctor. If not, then they are coming to the pediatrician. By the time they come to the pediatrician, the golden period of 48 hours is already happening, and the child is coughing very badly. That is the initial sign. We should educate that any child who is coughing very badly, it should be mostly viral. If it is day and night is equal, don't neglect, and we should educate them, sir. So most of the times the usually our area is like more like an educated parents, so they will see for 2 days definitely, and if the child is not improving with the existing medicines, then they will rush to the hospital. But every doctor from IAP also, we should give the recommendation that how to identify red flags. At least red flags we need to make sure that every parent should be aware of.
Great, great answer. Because they treat for 2 days, 3 days, they will come to the pediatrician on fourth day and have more questions to bullets onto the pediatrician, so that we should ready for the counseling part also. And next question, sir, Sri Krishna garu, should Oseltamivir be started empirically or after investigation?
As we have discussed with 2, 3 cases, where it should be whenever there is suspicion of viral LRTA, lower respiratory tract involvement, that is a breathlessness, cough, cold with breathlessness, and the even upper airway also involved. It has to be the viral LRTA. I mean, common causes for viral LRTA in this particular season are RSV and influenza virus. So in that RSV, still there is no definitive treatment, whereas by giving oseltamivir, we can save many cases of the, influenza cases, and even from its complications.
Okay, sir. Great. So, better to start Oseltamivir empirically if you suspect the case of viral illness, influenza-like illness. So, the next question is, Pawan, what are the factors on which clinical response to Oseltamivir depends?
So this is a very important question where we need to understand, sir, the timing of the treatment, the patient age, influenza type which the child is having, and underlying health conditions, everything. Vaccination status also influence the clinical response to oseltamivir. The timing, as we already discussed, earliest administration of oseltamivir within 48 hours of symptom onset is crucial for optimal effectiveness, reducing the duration of clinical illness, and also the viral shedding. What is most important, why we are stressing upon early initiation, is the viral shedding can be stopped so that further progression of the disease can be halted. And influenza type, luckily we have this, influenza is more dangerous than B, but we have a drug which covers both. So that is most important is underlying health condition. The children with chronic health conditions, especially TB, HIV, and the children on steroid therapy, immunodeficiency states like malnutrition. India, 1/4, almost 1/3 of the children are malnourished. So we need to be really careful. So those things will definitely influence the response, clinical response of oseltamivir. Even the vaccination status, vaccination history, we just ask the vaccination and the child got the vaccination. That can also have the impact on the duration of the illness and also the viral shedding. So these
Yes, sir.
factors we need to really keep in mind.
That's correct, sir. And the recent article says that once you start the oseltamivir, better to complete the total course of 5 days. And if
Right.
your child is vaccinated also, if the child is
Yes.
vaccinated also, if the child is having influenza-like illness, and if you suspect further if the parent says that child was vaccinated for influenza also. So we can't, because the genetic variation is that much. So we have to keep in mind Oseltamivir can be started and should be completed the course of 5 days. So
Very true.
next, Sri Krishna garu, generally how long should Oseltamivir be administered, sir? Already informed, but it's a 1 hour
Yes, yes,
session,
yes.
but new doctors would have added. So for
Yes.
them, how long should Oseltamivir be administered?
Here is a standard guidelines which are given. This particular chart, as Dr. Pawan already told, that we need to keep this over the table as a that what is the doses. If you see that the actually per kg body weight, it is a 3 mg per kg body weight. The only thing is for adults, the 75 mg capsule is available. For the treatment, you should give 75 mg capsule twice daily. For chemoprophylaxis, it is once a day for 10 days. That means if you calculate the total dose, it is same. That is like a adult 75 mg capsule, total 10 should be taken. For when you are treating the case, to give twice daily. That is a double the dose within 5 days. When you are giving as a chemoprophylaxis, daily one tablet for 10 days. So in the same way, when you come to the suspension formula, it is available as a 1 ml contains 12 mg. So this suspension can be given as per the weight of the child. For less than 15 kgs, you can give 60 mg per day, which is again divided into two divided doses. And between 15 to 23 kgs, it is 90 mg per day. And between 23 to 40 kgs is 120 mg per day, divided in two doses for the therapy. Whereas when you are giving as a chemoprophylaxis, same dose, you half the dose. That means instead of giving twice, give once a day, but you prolong the duration to 10 days. These are, you can see, but still, if those find it difficult to remember these calculation, they can keep just a sheet of this so that you can directly they can use it.
Yes. That's great, sir. And Dr. Pawan, do you prescribe antibiotics concurrently? Normally, better confusion is there that between bacterial and viral. So,
Yeah.
do you prescribe antibiotics concurrently?
Yes, sir. Definitely no antibiotics in flu management if it is sure that, it is a flu. Usually we don't typically prescribe in the OPDs or in the admitted cases unless there is a secondary bacterial infection. There is an evidence of secondary bacterial infection in terms of pneumonia, sinusitis, sepsis, and otitis media. We all know that flu is a viral infection and antibiotics are ineffective against the viruses, and overuse of antibiotics can contribute to antibiotic resistance, which all pediatricians, we never want it to happen. So definitely no, sir. But as per the IMNC policy and hospital policy, where you can't differentiate between viral versus bacterial infection, then definitely as a benefit of doubt to give, there is a first line antibiotic like amoxicillin can be given as per the IMNCI policy.
Thank you, Pawan. The next question is, yes, Oseltamivir is in our experience of 6 to 7 years. Oseltamivir is very much well tolerated, but on records there are so many adverse effects of Oseltamivir. Can you, sir, Surambud Sri Krishna garu, can you enlighten on that, sir?
We have used for more than 100 cases in last season, but I have not found any particular serious reaction with Oseltamivir. And the report say that literature says that there can be a serious skin reaction like blistering, peeling, or loosening of the skin, or red skin lesions, severe acne, or sores, or ulcers, or fevers, or chills. Whenever you find this, immediately stop the medicine.
So great, sir. So there are not that much side effects about the
Yes.
Oseltamivir. So, Dr. Pawan, any contraindications or precautions to use Oseltamivir?
Usually, generally, sir, it is well tolerated. Oseltamivir is well tolerated in children, but some contraindications and precautions we should take, like hypersensitivity. If there is a known hypersensitivity to oseltamivir or its components, better to be careful not to repeat it. And renal impairment, dose adjustment may be necessary for children with renal impairment. In some cases, there is very remote chances that it can increase the risk of seizures. So the child who is known to have seizures, we need to be little cautious in them. And precautions wise, usually oseltamivir is applied in children above 1 year. So the safety and efficacy in younger infants has to be studied. And pregnancy, and it's a type category C drug in pregnancy. So benefit should be outweighed of the potential risks, and the monitoring of the patient for signs of these symptoms. Most common side effects we see are nausea, vomitings, diarrhea, and headache. These are sometimes they may come, but if you use it according to the recommended dosage and the treatment duration to minimize the risk and maximize the benefits, it's always advisable to use oseltamivir. By and large, it is well tolerated drug, sir. In my practice, I have not seen anybody complaining any side effects. But only thing is the bitterness of the taste that can be masked by diluting it with double dilution, something like that.
Yes, yes. There are few contraindications, but when the treatment part and when it reduces the hospitalizations, when it improves the child, these things, a few things which are on given on the book or records will be definitely will not consider that much. So this is the best drug what we see nowadays. And so the key home messages is proper diagnosis can and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory complications, hospitalizations, and also antibiotic use. And WHO, American Thoracic Society, and Ministry of Health and Family Welfare recommends empiric use of oseltamivir. So I should thank my panelists, Dr. Sri Krishna Garu and Dr. Pawan, for telling their experiences and how they treat the case in OPD and what are the indications and what will be the outcome of the oseltamivir if you start early or empirically. So really, this will be benefiting for ourselves and also for the listening doctors. Thank you very much.
Thank you very much.
Thank you, sir. Thank you.
Thank you.
For all those who are listening, patients will thank you if you start it early, and they can see that there is a sea change. They will appreciate you as a very good doctor because you have identified it in early and started them and good treatment. And you can see the results in 48 hours. I can confidently tell that the cough will subside within 48 hours. You can see a change in the cough, and they will thank you for that.
Even I have seen actually the cases which showed rapid improvement after starting oseltamivir later, because viral panel will take time. After that, what I have noticed that the cases which are really positive for influenza, they show dramatic result and a very quick effective. Within 2 days, there is a gross change in the children. So definitely we recommend this condition, this drug for it.
Okay, sir. Yeah, Smita, please. Unable to hear Smita. Unable to hear Smita. Not able to hear.
Hello. Am I audible now, sir?
Yes.
Sir, Smita, this side. Actually, I would like to thank you, Dr. Sridhar, Pawan Kumar, and Sri Krishna, on behalf of Hetero family. Also, I would like to thank all the joining doctor for this wonderful session. Thanks a lot, sir.
Thank you.
Yes, sir.
Thank you.
Thank you, sir.
Thank you, Sri Krishna Garu. Thank you, Pawan.
Thank you.
Thank you, doctors.
Thank you.